Start recording.
Yeah.
Welcome, everybody. Thank you for joining us, and Happy New Year for those who I haven't seen yet. I hope you're doing well in the circumstances. And tonight we'll be doing a tutorial on probably one of the most requested topics because it's not very well taught at UCL. And it's a very wide topic, which is to say antibiotics. I don't think we're going to claim to cover everything you need to know for antibiotics. But the idea is this will give you a general introduction to most antibiotics that you'll encounter in your clinical years. And it will give you a nice framework to take on more information that we'll be giving in subsequent tutorials. Okay. The structure that we're going to do it on is we're going to split the antibiotics into sort of three main mechanisms of action. Those that target the cell wall, those that target protein synthesis, and those that either target DNA synthesis or are just a bit of an oddball-y kind of antibiotic. I would say that beyond splitting antibiotics into these three categories, you don't really need to know too much about the exact mechanism. You know, if it's protein synthesis, whether it's 30S or 50S, I don't think it matters that much. Most important thing is it's protein synthesis. Some of these antibiotics tend to be bactericidal, and they sometimes are bacteriostatic. To start, can anyone tell me the difference between bactericidal antibiotics and bacteriostatic? And for bonus points, why is this clinically relevant? Also, the clue is kind of in the name. If you're struggling, static versus sidal. Yes, exactly, Davina. So bactericidal antibiotics actually kill the bacteria. So what does that mean about bacteriostatic antibiotics? Yeah, exactly. They prevent replication. Well done, Registry. So they don't kill the bacteria directly, but they stop the bacteria from replicating. So they stop the spread of infection and allow the immune system to sort of kick in and tidy it up. And now that we know that information, why do you think that's clinically relevant? Why do you think we need to know whether an antibiotic is bactericidal or bacteriostatic? When does it matter? If you're not sure, think about which patients we might want to have to give bactericidal antibiotics to. Yeah, exactly, Kian. Well done. So in people without an intact immune system, we can't just give bacteriostatic antibiotics because there's nothing there to mop up the remaining infection. We need to make sure we give a combination maybe of bacteriostatic and bactericidal antibiotics. It also happens to be the case that for more serious infections, we tend to favour the bactericidal. So it is useful to have that differentiation. So, like we said, we're going to split antibiotics into three main types, and we are going to consider these sort of things. We're going to talk about the sort of broad classes and give you examples. You'll understand the main roles, so when we use which class of antibiotics, and important side effects, which gets tested a lot in SBAs. And then we've got some summaries at the end and a few SBAs for you to sort of get used to. All right. So we'll start with the first one, cell walls. So cell wall antibiotics tend to be bactericidal because if a bacteria doesn't have a cell wall, it doesn't maintain osmosis, it bursts. So living bacteria. It tends to be better for gram-positive bacteria rather than gram-negative, because if you remember, the gram-positive ones have a slightly different cell wall structure, which means they're a bit more vulnerable to these types of antibiotics. Could anyone give me examples of cell wall targeting antibiotics? Penicillin, fantastic, Priya, well done. Any others? So penicillin is a very common one. Any others similar to penicillin? Cephalosporins, fantastic, Maddie. So that's another one of the beta-lactams. There's a third type. Can anyone give me that? Or the other cell wall targeting one? Okay, we'll just move on for time. So you're absolutely right. We've got. Oh, I should have said. One of the things that we're going to do with this lecture is we're going to characterize each class of antibiotic as a hero from the Avengers, because we think that might make it a bit easier to remember, might make it a bit more fun, and also we're trying to get to the point that you don't need to remember specific things, but if you understand characteristics of classes of antibiotics, if you understand what they're generally good for, you'll really go a long way. Okay, so we've got our beta-lactams, which are the core Avengers. We've got Iron Man, penicillin, and we'll explain why it's Iron Man a bit. We've got Captain America as cephalosporins, and carbapenems is the third group of beta-lactams, and that's the Hulk, and we'll go into why later. Aside from the beta-lactams, you have the glycopeptides, like vancomycin, and those also target the cell wall and are very useful in resistance. Okay, I will hand over to Anush to take over.
Yeah, I will preface this with you will, even if you haven't seen any of the movies or read any comic books, you don't need to know any of that. So bear with us. It's just I think James will probably agree. Antibiotics are quite dry generally to learn. So this was like the most exciting way we could, well, it's mainly James's idea that we could come up with to kind of get it a bit interesting. Right, so here is a starter SBA for you. If you look in the chat, there's a Menti code that should hopefully work and you can have a go at this SBA. Is it working? It is working. Okay, I've got one person who's answered.
Anush, I don't think they can see the SBA. Can you mute? Have you taken control of my slide?
Wait, I haven't taken control.
There we go.
Good point. Sorry. Yeah, here we go. Thank you. Getting rusty. I haven't taught for like a week. There you go. Now have a go. To be fair, it's impressive. Someone got it right, having not seen the question. Pretty good. 1 in 5 chance. A few more seconds. Let a few more people answer. Ooh, okay. So there's a bit of a split. So the correct answer is serum tryptase. And we'll go through what the other answers show. But what kind of reaction is this? So I would say this is like a classic 2-step UCL question. Yeah, so it's mast cell degranulation, which is what type of hypersensitivity reaction? If you go back to first year, it is quite the throwback, I know. But this is one of the useful things from first year. Any ideas what types? So there's 5 types of hypersensitivity reaction. So not type 3. That is a pure. So mast cell degranulation is a type 1 hypersensitivity reaction. It's the most severe type. So it's the first one because it's the one that can kill, is the way I would remember it. So IgE-mediated mast cell release. And effectively, the common name for this is anaphylaxis. And the best test to confirm whether the reaction is a true anaphylaxis reaction or it's something mimicking anaphylaxis is you can test this thing called tryptase a few hours after the incident, and it should be raised. If it's not a true anaphylaxis reaction. Serum amylase will be raised in pancreatitis or in mumps. Serum lipase will be raised in pancreatitis. Urine metanephrines is the test for apheochromocytoma. And an ABG can be used for a multitude of things, but is generally used in acute shortness of breath as an acute investigation. Cool. So, and the reason we're going to, so anaphylaxis is a huge deal when it comes to penicillin-based antibiotics. So here's some very little biochemistry, but does anyone know what this is, what this ring represents? I promise you this is the only biochemistry in this lecture. There is no more. I would argue this might be the only biochemistry in 4th year, potentially. This is the beta-lactam ring, and this is like an integral part of how penicillin and other beta-lactam antibiotics work. And the key thing is, this is intrinsic to how these work and how they disrupt cell wall synthesis. People can be allergic to either penicillin specifically, or they can be allergic to this ring in general. So if you take 100 people who have a penicillin allergy, around 10 of those people will also be allergic to other beta-lactam-based antibiotics like cephalosporins or carbapenems. So if someone has a recorded anaphylaxis reaction to penicillin, you don't give them any of the antibiotics from this class. That is the most important. Like, forget spectrum of activity and like when you use penicillins, but the single most important thing to know about penicillins is allergies, because this could kill someone. Okay, let's talk about penicillins. To understand the various penicillins, we need to talk a little bit about what they were created for and like kind of the history of penicillins. So penicillins, we decided Iron Man would be suitable because every time they realized that penicillins weren't great, they went away and they made a better version of penicillins. So problem number one. So the original penicillin, the very first antibiotic they created was benzoyl penicillin, and it was an IV drug. Worked well against strep, chest infections, and some gram-negative infections. But it's an IV drug. You can't give it to people like at home, which is a huge problem because we have limited hospital space. Don't want to bring people into hospital. And a big problem during this period of time was actually rheumatic fever. So rheumatic fever was still pretty common in children. And to prevent rheumatic fever, you need to treat the strep infection that can cause it. So they produced Pen-V, which was an oral version that was very good against streptococcus. So the problem with this is it lost gram-negative activity. So that's our first problem. We need an oral drug that is good against both gram-positive and gram-negative. What modern-day antibiotic that we use today for almost all infections? If you go to the GP with like an ear infection, they'll give you this that covers both gram-positive and gram-negative. What's like the commonest antibiotic you've seen? Amoxicillin, and that was the solution. So amoxicillin, oral drug, good gram-positive cover against streps and some gram-negative cover. Fluclox is also great. It would do all of these things, but we reserve it for something else, and we'll talk about that in a minute. Fluclox is a newer drug. So the next problem is Staph aureus. This is like a commensal on our skins. So if you swab most of us, you'll get some form of Staph aureus, but it's resistant to all penicillins until this point. What does anyone know why it's resistant to penicillins? So there's two types of resistance. So Staph aureus produces its own beta lactamase inhibitor. It's intrinsically resistant. It hasn't developed this over time. It has always been resistant. This is one of the ones where it hasn't come due to antibiotic misuse. It's always been resistant. So we had to produce a version of amoxicillin that was resistant to this inhibitor. Does anyone know what that's called? We have it today. Someone's already mentioned it. So we're not adding a beta lactamase inhibitor. So that's when you add an extra inhibitor. But what we actually did was produce an antibiotic which was just resistant to this enzyme. Yeah, and that's Fluclox. So it's slightly weaker, but it's completely resistant against beta-lactamase, which is the enzyme that Staph aureus produces to break down amoxicillin. It's completely resistant, so it works very well. But the problem with this is other bacteria were becoming resistant to penicillin. So this is the acquired resistance that comes along with time as people don't complete their antibiotic doses and courses. So what the next thing we can do is add an inhibitor, like a beta-lactamase inhibitor, to any penicillin, and that's what you just mentioned. That's co-amoxiclav. So that's our final improvement. So we added clavulanic acid, so it continues to facilitate amoxicillin working, and it had the added benefit of it works against anaerobic bacteria. I don't know why, if I'm honest. I don't know the biochemistry. I don't think James does either. No, he doesn't. So yeah, I wouldn't worry about it. So just to recap, modern day uses of penicillin. This is what you need to know. If you've got skin infections, which might be staph, what antibiotic are you going to use? Yeah, yes, Fluflux. If you've got a community-acquired pneumonia, which is usually caused by a strep infection, what are you going to use? You might have heard of the CURB score. We're not going to cover that today. The CURB score is very good, but yeah, if it's mild, and it's a strep infection, amoxicillin. If you've got a severe community-acquired pneumonia and you're worried that it's severe and it's not going to respond to amoxicillin, what are you going to use? You're going to use co-amox because you can't afford to get it wrong. Because if it is resistant, they're going to get even more ill. Absolutely. And then strep throat, where it's definitely strep and it's nothing else. And you don't want to treat them with something broad spectrum. What are you going to use? So a kid comes in with a sore throat. You don't want to give them something broad spectrum. So a tablet that only hits strep. What was the the second thing we made historically? Yeah, Pen V. Ben Pen you can use if they're really ill and they're in hospital, but you can't. We tend not to because it's IV. Amoxicillin, there is a risk. So, like, if someone has a throat infection, it may also be caused by a virus, and if you give them amoxicillin, they might get a reaction. James is smiling because he has something to add because the evidence is kind of iffy.
Yeah, I mean, for SBA world, we can pretend that amoxicillin. The reason why you don't want to give it is if someone's actually got EBV, which is the cause of their sore throat. Apparently, amoxicillin can give you a widespread maculopapular rash. I'll speak at the end about why that might not actually be the case, but SBA world, let's pretend.
Yeah. So Pen V. Cephalosporins. So that's everything you need to know about penicillins, pretty much. You might see some stronger penicillins, such as tizocin, but like we're not going to talk about that today because they're not really commonly used. You might use them in like certain emergencies, but like that's more a fifth year topic again because it's like hematological stuff, oncology stuff. Yeah, cephalosporins. We assign Captain America because they're IV only, but they're really old drugs. Yet again, they were developed like not long after penicillin. Very reliable because they work for pretty much any infection. Like anything that isn't an anaerobic infection, these will work. And the important thing to know for exams is if someone's got like meningitis, you're going to give them cephalosporins because they can easily cross the blood-brain barrier. You can also use them in kidney infections. Less important. Meningitis is your takeaway point from this slide. And here's something for you to read over. Like they won't ask you about this in exams, but it's kind of interesting. You can guess the generation they're from, but it's not coming up. Carbapenems are the Hulk because of a very important. So basically, right? If any of you've watched Avengers movies, which I hope you have because they're good movies, You don't really bring the Hulk in unless the situation is really, really, really bad, because the Hulk is very unstable. So you don't use carbapenems unless it's a really, really bad infection. Almost nothing is resistant to carbapenems because we avoid using them, and we reserve them for these really bad infections. And one of the reasons we don't use them is they're neurotoxic. They will mess with your mind. They can cause you to become very ill as a side effect. So if you can't remember what carbapenems do, just try and think of the Hulk and Hulk getting angry, and just don't use carbapenems in an OSCE. You will never need to you will never prescribe one of these in an OSCE. I think this is James.
Yeah, so this is probably the last type of cell wall affecting antibiotic. And this was also another answer to antibiotic resistance. So this one doesn't have a beta-lactam ring. So those that produced beta-lactamases, we might use this. The other thing to say is the reason why these came really into the forefront was because of MRSA, which was insensitive to things like flucloxacillin, which was one of the things that we used to counter the beta-lactamase things. They work. We've chosen Hawkeye for this because we use them in very specific scenarios. Okay, so the way they work is they're quite a big protein. They get incorporated into cell walls and they disrupt them. Like Hawkeye goes behind enemy lines and disrupts them. It's a very much of a specialist. We don't use this in sort of that many infections. We use it in very specific cases. So MRSA, C. diff are the main kind of uses. The other one to mention, which I haven't put on the slides, is Staph epidermidis. So Staphylococcus epidermidis. Does anyone know when we typically see those kind of infections? Those doing Mod B might know about that.
Don't forget to take control, by the way.
Apologies. Thank you. I'm also rusty. Yeah, prosthetic joints. Things where you can form biofilms. So Staph epidermidis is like 90% of Staph epidermidis is resistant to Flucox, so we just give vancomycin straight away. And we usually give vancomycin IV because it has really, really poor oral absorption. It just doesn't get absorbed from our intestines. Can anyone think when that actually might be useful? And there's a clue on the slide for in one of its other uses. So when might we give oral vancomycin? Fantastic, Chris. H. pylori, we tend not to give vancomycin. It's a very good idea. Both are in the same theory. We would give it if it's an enteric infection. Okay, so C. diff affecting the bowels, we'll give vancomycin. It doesn't matter that it's not absorbed that well because we don't want it to be absorbed into the bloodstream. We want it to stay in the gut and target the bacteria in the gut. So that's the only real times we'd give oral vancomycin. Otherwise, we give it IV. There are some sort of very common, or not very common, very SBA world side effects that you see with vancomycin. Can anyone name them for me? There's one big one. Cool. Okay, there's some clues here for the rest of you who've not seen it. So, as Jordan says, it's red man syndrome. Okay, so if you see pictures of this and they say they've recently been on IV antibiotics, think alarm bells, think red man syndrome, think vancomycin. However, SBAs aren't often this easy, and they'll try and describe it in words because they know you'll see a picture of someone who's red and go, oh, that's red man. So you might see these things instead. Intense pruritus, widespread erythematous, rash involving the whole upper body shortly after receiving IV antibiotics. If you see this shortly after receiving IV antibiotics, that should be an alarm bell, not just for vancomycin, but for other side effects from, allergic anaphylaxis, things like that. So see these clues, whether it's from the pictures or whether it's from the words, and think red man syndrome. This is another hypersensitivity reaction, and it's widespread histamine release. It doesn't often end up affecting the airways, but it's especially common if you infuse the drugs fast. So there's always limits on vancomycin, and usually this doesn't happen now because we give it at quite a slow rate. Other common side effects are nephrotoxicity, ototoxicity, and occasionally thrombophlebitis, but that also comes with infusing fast. Okay, so on to the next sort of type of antibiotics, protein synthesis. And these are largely bacteriostatic, because if you think about if we stop the bacteria from producing proteins, we just stop them from growing and replicating, but it's not actually really going to kill them that well. The one exception is aminoglycosides, and I'll go into why in the next few slides. Generally, these are also quite broad spectrum, because whether you're gram-positive or gram-negative, you need to make proteins. Can anyone name some protein synthesis sort of targeting antibiotic classes? Might not be quite so easy as penicillins and things, but I'm sure you'll get there. Macrolides, fantastic. That's one of them. There's another two that I've got.
But one of them's on the slide, so it's cheating.
Oh, yeah, good point. Yeah, aminoglycosides. And the third, I would say this one's the roguest. Yeah, well done, Zach.
Sorry, outed.
Okay. Oh, yeah, the third is tetracyclines. Okay, so we've gone for Guardians of the Galaxy for this one. Macrolides, I've chosen Gamora mostly because she's green, and green we're thinking GI side effects. But also, you know, she's reliable. We use them in penicillin allergies. They're very good. Aminoglycosides, similar to the Hulk, quite a big hitter. So that's the one protein synthesis antibiotic that's bactericidal, and we use it in serious infections like infective endocarditis. Similarly, like the Hulk, you do get pretty bad adverse effects, and it's ototoxicity and nephrotoxicity. Tetracyclines, we've gone for our lovely Chris Pratt. Star-Lord, because we're thinking about alien stuff. So it's useful in the alien infections, parasites, that sort of thing. And it looks the part, but it's not actually that helpful. It's probably not one of my, it's down there in my list of antibiotics. Not a big fan.
I mean, yeah, they use them a lot. They use them a lot, but like they shouldn't be using them a lot, but they use them a lot.
Yeah, not great. So examples of macrolides are your Erythromycin, Clarithromycin, and Azithromycin. You'll probably see Clary the most. And the reason why is Clary has less of the adverse side effects. So, like we said, it's fantastic for people who are penicillin allergic. So pretty much all infections where the first line is penicillin, if they're penicillin allergic, we tend to give a macrolide like Clarithromycin instead. So often very, very good to have that in your head. So you're not rote learning first line, second line, just most of the time it's macrolides if they're penicillin allergic. They're very good for atypical infections, a bit like the aliens, in pneumonias. So if it's not a typical pneumonia, if it's a sort of more indolent course, if it's not that classic, if they don't have the classic symptoms, then you might want to be thinking about adding a macrolide cover. They have GI side effects. These are really big, and that's an important one to know for SBAs. So lots of people feel very like they upset belly, they're nausea and vomiting, but it's also a prokinetic, so it can lead to diarrhea and things like that. Weirdly, we sometimes use that for its benefit. And it also can cause QTC prolongation. Does anyone know what heart condition may occur if we prolong the QT interval for too long? Torsade de pointes, exactly. So it's the sort of Arctic monkey crazy AM thing, and it can lead to ventricular fibrillation and death. So you do want to avoid that in people who have a prolonged QTC already. That's spelled perfectly right, Jordan. Yeah, you want to avoid macrolides in people who you know have a long QTC or have like congenital long QTC syndrome or other drugs that prolong the QT interval.
Just always do an ECG first.
Yeah. The interesting use of macrolide antibiotics is in diabetic gastric neuropathy. So if people complain of sort of constipation, weird bowel symptoms, delayed gastric emptying, you can give macrolides, I think it's second line though, to shove things on a bit and treat it. So that's why some diabetics might be given erythromycin even though they don't have an infection. Fun fact. Here's an SBA. I was horrible and tried to make it really mean. So don't worry if you have no idea what it's going on about, but we will talk through all points of it later. So have a go at that on your Menti. Whilst I guess
we discussed this. This is quite a mean SBA. If this came up in your exam, it would definitely be like the harder end of the spectrum.
I do think, though, it does test a lot of things that UCL love testing. So if you understand this question, it will still be really helpful. I'm getting some water. I'll be right back.
Menti is wrecked. It's telling me that 50 people have answered this poll. I'm almost certain that's wrong.
How's the polling going?
Menti's just wrecked. It's just not working at the moment.
Oh no. Okay. All right.
No. Oh wait, no, it's worked. Okay. So people have gone for a mix of B, C, B, and C.
B and C. Okay, that's very understandable. Those were the ones that I think I would have gone for too. The correct answer is B. So here are the reasons why. So this is getting at a drug reaction. At the end of the day, this question is getting at a drug reaction that UCL absolutely love to test. No, he was not, Zach. We'll go into that. So I've worked this out to be a four-step question if you do it the way I'm explaining it. So someone who's had an MI, they usually get put on 5 drugs, really. Does anyone know some of the drugs that you get put on post-MI? Apologies if you haven't done Mod A yet. Registry. Perfect. Really, really good. Yeah. Digoxin is usually for some types of heart failure or atrial fibrillation, Maddie, but very good guess. That is a cardiac drug. But Registry's hit the nail on the head. You have these 5 drugs: ACE inhibitor, beta blocker, dual antiplatelets, and a statin. And the statin is relevant in this question. When you get a cap, with a curve score of 4, you put them on Coamox and Clarithromycin. So this is just a small bit of the curve scores and what you get given. On 3 and 5, you add Clarithromycin from curve scores of 2 and above for the atypical cover. But we're really getting at this interaction between Clarithromycin and atorvastatin. Can anyone describe the urine to me? Reddish, yeah. I would go, if you had to think of it as a drink, what kind of drink does it look like? Frothy, dark and frothy, that's great. Yeah, great, well done. Coke, yeah, exactly. So this is Coke-coloured urine, which is suggesting myoglobin being passed in the urine, suggesting there's something wrong with the muscles. The other clinical points to say is because his shortness of breath is improving, it's perhaps suggesting that it's not necessarily the infection that's causing his deterioration on day 5, because we're treating the pneumonia, he's getting better, but then this thing's happened. Okay, so the brownish urine, Coke-coloured urine, which is just rhabdomyolysis, breakdown of the muscles. And this is because of the interaction between macrolides and statins, which should never, never, never be given together. The reason why is because clarithromycin inhibits P450 enzymes, which means you have a buildup of statins. So when you don't have the liver enzymes working to break down drugs, the statin levels go high and high and high. And when statin levels climb up, there's an increased risk of myopathy, but also rhabdomyolysis. So in this case, you want to do urine electrolytes to check the kidney function, and then creatinine kinase levels to confirm rhabdomyolysis. Blood cultures would be useful clinically if he, if he develops another fever, other things like that. But because there's the clinical signs that his infection's improving, and because of these interactions that are well known, I'd be more inclined to do B. This is an interaction that gets tested a lot, so do keep an eye out for it. And I have seen it being slid in as simple as giving their past medical history and not telling you what drugs they're on. So do also be wary of that. Anything to add, Anush?
I guess it's briefly worth going over the other results. So you do LFTs if they were jaundiced. Some antibiotics can cause jaundice. but like there's no evidence of jaundice here. Muscle biopsy is almost exclusively for if you're worried about like an inflammatory myopathy. If you've done Mod B, inflammatory myopathies aren't going to come on, and like they shouldn't be coming on like this acutely and with other stuff going on. Urinary Bence-Jones proteins. Anyone done Mod C? Anyone know what you're testing for there? Yeah, multiple myeloma it's a really good test for multiple myeloma. But yeah, so learning points from this question are everyone who's had an MI is started on a statin. Clarithromycin inhibits the does it inhibit? Yes, it inhibits the P450 system. Those are like your two learning points. And I guess the third learning point from this lecture is they love testing side effects and interactions. You're way more likely to get tested on side effects and interactions than you are on indications, I would argue.
Agreed. Yeah, 100%. Yes. So clinically, what would happen is we'd hold the statin when we start the clarithromycin, and then we start it again afterwards. Okay. Very good though. It's a tough question, so don't worry. Don't be disheartened if you went for C or any other.
A lot of you got it right, which is really impressive.
Yeah.
Yeah.
Yeah. Honestly, well done. Okay, so moving on to other classes of protein synthesis drugs, we've got 4 aminoglycosides. So examples of this are the mycin, so gentamicin, amikacin, tobramycin. I've underlined tobramycin because it's particularly useful for pseudomonal infections, and we'll go into that on a later slide. So like we said, excellent gram-negative cover, so it's really useful as an add-on. So for example, an infective endocarditis, we can add it on if we're worried about gram-negative. It's particularly good for endocarditis, as I said. Side effects are nephrotoxicity and ototoxicity, and very niche, very small point, if you have neuromuscular conditions like myasthenia gravis, as I mentioned earlier today, it can worsen that, so it can cause neuromuscular blockade. Nothing much more to add to that, though. Okay, tetracyclines. So again, think of this one as being the alien one. So it's really useful for alien infections, so parasites, things like Lyme's disease, other tropical illnesses, that kind of thing. You tend to start on doxycycline. Okay. The other thing is it has a list of really weird side effects, and we'll go into that in the next slide. So I don't know why it's showing all the animations straight away. Can anyone tell me any of these known side effects of tetracyclines? I would say the top left is probably the most obscure. It's not that clear, but the others might be.
Ironic. It's the least clear from the image, but it is by far the most common in real life.
Indeed. Good. Yeah. So say what you see. Yeah. Black tongue. So black hairy tongue is what, if you want the full name. Photosensitivity. Well done, Isabella. So that's the top left. Does it also give you weird dreams? I don't know about that one, Anush. I think I know beta blockers do, and I know like nicotine replacement does.
I think it can. I think it can. I mean, it's not going to come up in exams, but I think it can. It causes like vivid dreaming, I think, is the textbook term.
Interesting. There we go. And what's the bottom left one? Yellow teeth, discolored teeth. Yeah, so it causes discoloration to teeth and growing teeth particularly. So we've got photosensitivity, brown discoloration of growing teeth, or known as tetracycline teeth is how I remember it. Yeah. And it's the reason why you avoid it in pregnant women and children, because you don't, when it's growing teeth, you don't want them to be on tetracyclines. And then say what you see, black hairy tongue. Weirdly, it gets linked to this a lot, but the most common cause of black hairy tongue is actually just poor oral hygiene. But SBA world, here you are, enjoy. Okay, so on to the third and final main type, DNA synthesis and oddballs. Oh, the one thing I meant to talk about why aminoglycosides are bactericidal rather than bacteriostatic like the other protein synthesis ones, and it's because on top of just stopping protein synthesis, it also inhibits the translation checker. So you develop mutations in the proteins as well as just stopping the proteins from developing. And when you have mutated proteins, they do weird functions and cause the cell to die. So aminoglycosides are the one sort of protein synthesis one that are bactericidal rather than static. But yes, back on the road show, we are talking about DNA synthesis oddballs. So these are mostly bactericidal because if you can't synthesize DNA, that's not good. The one sort of exception is trimethoprim, which is only bacteriostatic, but when it's combined with sulfamethoxazole to form cotrimoxazole, it's bactericidal. So most are bactericidal. Trimethoprim by itself is bacteriostatic, but you add a boost and it's bactericidal. Okay, so here we've got the flash for fluoroquinolones. We've got ciprofloxacin, levofloxacin, and moxifloxacin. So floxacins. So
all of these are non-Marvel characters. We are aware.
Apologies.
Before someone calls us out for it.
They are super fast, so they've got fantastic bioavailability to the extent that you can give them orally, you can give them IV, and they have the same bioavailability. It's the only oral anti-pseudomonal agent, so again with the bioavailability. So ciprofloxacin is the one that we use for pseudomonas if we can only give it orally. But one of the side effects, thinking about running, if you run fast, you can rupture your Achilles tendon. So it's just a very weird random side effect that they love testing. Okay, Anush is covering for metronidazole.
Yeah, so metronidazole so what I want you to think about is how Batman kind of takes out like the parasites that infest his city, because metronidazole is used for, like doxycycline, is used for like lots and lots of weird parasites. But other than that, it's useful in that it's very good against anaerobic bacteria, especially in the GI tract. So we'll talk about C. diff briefly in a bit, but if someone's had a previous course of antibiotics and then they go on and get like C. diff diarrhea, you give them metronidazole and it works very well in most patients. If it doesn't work well, then you can give them vancomycin, as James said earlier, but like your first line is metronidazole. So anaerobic bacteria that are hiding away, it's very good. The important reaction you need to know about is what happens if you drink alcohol while you're taking a course of metronidazole. Does anyone know, or has anyone done this before? Someone in my year did this, and he did not have a good time.
Name and shame, Anush. Name and shame.
No naming and shaming. Suppose I had to take metronidazole. That's bad enough. Yeah, it's basically it's called the disulfiram reaction. It's like it's like antabuse basically. So they get flushing, nausea, vomiting, and they feel super unwell. It's called the disulfiram reaction. So do not drink. Warn patients to not drink alcohol while they're on metronidazole. They will not have fun. So those are like the main things to know for metronidazole. Oh, here you go. You're muted.
God, I'm so rusty. We've got trimethoprim, another one of my sort of least favorite antibiotics. It's not that useful unless we sort of boost it up a bit. So it's an antifolate. So with it, we've got Aquaman here in his nice green trousers. Just think green leafy foods, antifolate. It's useful in UTIs, thinking of the sea. That's the only sort of most common use you'll see trimethoprim in our sort of clinical years. And then when we boost trimethoprim a little bit, if we put him on his sort of seahorse, we turn him to cotrimoxazole, which is bactericidal rather than bacteriostatic. I mean, it's useful to remember that because often SBAs will try and trick you by using cotrimoxazole and making you forget that it's trimethoprim and sulfamethoxazole for adverse reactions. So every time you think C cotrimoxazole, it's always worth writing out or having a mental note, okay, it's both of these antibiotics. Another SBA for you. Okay, so we've got a 66-year-old lady with a very extensive past medical history, bless her. And she's found to have pneumocystis urevecii pneumonia, so started on cotrimox. Which of her following regular medications should you temporarily stop? Because
this is like
very attentive.
This is a very classic exam question. This comes up like, did it come up last year, James?
Oh God, I've blanked out last year's SBAs, so sorry.
Yeah, this came up when I was in 4th year because they love testing this reaction. We'll give you 30 seconds. Or less, because more of you have answered. I guess there's 1.5 right answers to this, right, James?
Yeah, and I'll go into that in the next. Wait, hang on. We'll discuss. Hang on.
We will discuss. So the right answer for this one. Go on. So people went for most went for B, some went for D, some went for E.
Okay, all right. So I've coloured D in a yellow because I think people who chose that are thinking along the right lines. So let's start with the correct answer. So methotrexate is also an antifolate drug. So when we combine trimethoprim and methotrexate, the folate inhibition, they both target the same enzyme. So you get complete bone marrow suppression, which can cause pancytopenia. So you need to avoid that. So again, you'd halt the methotrexate. The people who voted for sulfasalazine, I can totally see why you've done that, because again, this is a reaction that gets tested a lot, but it's more of a specific thing. So sulfasalazine and sulfonamides, which are also in cotrimoxazole, are sulfa drugs. So if someone has demonstrated an allergy to sulfasalazine, they should also avoid sulfonamides, so should not be put on cotrimoxazole. But someone who doesn't have, you can have both safely, but it's just, again, like with the penicillins, cross-reactivity. So if you're allergic to the sulfur group in sulfasalazine, you're probably going to be allergic to sulfonamides. But this is sort of a very sneaky SBA that will trick you into thinking, oh, there are these adverse reactions, but you need to be specific as to why this is relevant. So in this lady, because there's no previous documented adverse reaction to sulfasalazine, it's absolutely fine to give her sulfonamides and therefore cotrimoxazole. Just to test your general farm, let's talk about what the other drugs are. So lisinopril, when do we use that? What type of drug is it? What of her past medical history is it treating? Good. ACE inhibitor for hypertension, fantastic. Methotrexate, we discussed as an antifolate. Which of her history is that treating? Good, rheumatoid arthritis, because it's a DMARD, as is sulfasalazine. Doxazazine, what's that? What class is it? Let's talk about that, and what might it be used for? Alpha antagonist, not agonist, but you're right about the target, alpha. Tamsulosin is the one that we typically use for BPH. I think doxazazine can actually be used for that as well. But yes, it's an alpha blocker, and it can be used in hypertension. It's like fourth line. It's not used that commonly, but you actually see it in quite a lot of patients because it's quite an old drug and elderly people stay on it. But it causes a lot of postural hypertension because of its alpha blocking action. So it's quite a bad drug. We tend to take people off it when we can. Warfarin, we use it in AF because it's an anticoagulant.
I think doxazosine is more centrally acting and tamsulosin is more peripherally acting. So like generally, yeah, you so if you see doxazosine, you're thinking hypertension. If you see BPH, if you see tamsulosin, you're thinking BPH.
Right. Thanks, Anush. Okay. Oh, as a bonus, if this 66-year-old lady came with a diagnosis of pneumocystis jirovecii pneumonia, if the investigation had not been done yet, what should you definitely do before discharging her?
This is fifth theory, but like it's good knowledge, which is why it's a bonus.
Very, very good. HIV, yeah. So pneumocystis jirovecii is a HIV-associated infection. It's an opportunistic one, and it only really happens when your CD4 cells dip below 200, I think. It is actually, I'd say it is worth knowing a few of the opportunistic infections in HIV because they crop up. So this would come in pneumonia. The other ones to know are sort of come up.
You pick it up off plasmid anyway.
Yeah, it's true. It's true.
Because it'll test you on it.
Okay, so here's a few of, to finish off, here's just a few sort of our cheat sheets. So here are the anti-pseudomonal agents. Top choice coming at number 1 is Tazocin, which Anush mentioned earlier is sort of an upgrade on coamoxiclav. So it's piperacillin and tazobactam, and it's very, very, very good. Second one is a carbapenem, so meropenem or imipenem. Third one is ceftazidime. Can anyone name the class of ceftazidime? Clue comes in the first part of the name.
Again, I wouldn't memorize this list. I would just, cephalosporin. I just remembered roughly what classes kind of work. Like, yeah, don't memorize the list.
Don't worry, you gave us an example, which is good. Ciprofloxacin, I think, is probably a one to remember, however, because it's the only one that's oral. Okay, and then the fifth one is tobramycin, which I mentioned earlier. Gentamicin does have an anti-pseudomonal action, but tobramycin is much better for it. The reason why it's useful to remember your anti-pseudomonal agents is it commonly comes as, like, in terms of infections in the hospital, ones that are particularly antibiotic resistant. Anti-pseudomonas sort of comes quite commonly. You see it in cystic fibrosis, you see it in people with chronic lung infections, you see it in diabetics with ear infections. Is the order of use? I think in terms of, if you had to choose one, I would go with Tazocin. I think it is the order of list that you go, but again, in terms of the specific patient, if you have in front of you, for example, if they want to be ambulatory, if they don't want to be on IV, you give ciprofloxacin instead. But maybe remember Tazocin and then Cipro.
I wouldn't. Yeah, I don't think the order is super important, especially because, like, what we're learning nowadays is, like, there's tons of Pseudomonas that's Cipro resistant, especially like imported Pseudomonas from, like, Asia, where they have less antibiotic governance. So I wouldn't worry too much. Just be aware of some of the various things you can use. Levofloxacin is not, so it's only Cipro. So when they created Levo and Moxie, the side effects are better than Cipro, but you lose the anti-pseudomonal effect, was the issue.
Very good question,
Roger. Really good question. But yeah, only Cipro of that class.
And I think I've tried to show that on the slides when you look back. Okay. The other cheat sheet is, like we said, side effects get tested a lot. So let's match the side effect to the drug. You don't have to go about it in order, but if you in your answer you put the side effect and then you put the drug in the same answer, that'll make it clear.
Yeah, or write it down on a piece of paper. It will give you, like, it's up to you how you want to do it. But this is really useful for exams. There is one drug we haven't talked about. Yeah, there's only one we haven't really talked about. Wow, I wish I had this slide when I was in fourth year. Yeah.
I wish I had a lot better antibiotic teaching. It's just such a it's such a broad topic that no one ever wants to discuss.
Yeah. Also, don't worry if, like, this is just an overview. What our plan kind of is to do is, like, well, when we teach other topics, antibiotics are kind of like a vertical module, but we might put, like, a slide or two about an antibiotic used in a specific scenario every week. So, like, this isn't something you can just sit down and learn in one go. This is just meant to be kind of an introduction more than anything.
And also, like, this would take time as well. So, like, the slides are there for you to look back in your own time, pick it up slowly, and once you get into the frame set of knowing which broad class is useful for what and knowing kind of characteristics of them, you'll be doing really well. Okay.
Yeah. I mean, you're already doing really well based on how you've been answering the SBA, so I wouldn't worry at all.
So just the answers. Here we go. Tendon rupture, ciprofloxacin, the flash one. Ampicillin or amoxicillin. So I'm being a pedant here, but ampicillin is the one that's known to give you a maculopapular rash. Amoxicillin is similarly related, which is why they suspected that you have the same thing, and which is why we give Pen V instead of amoxicillin for throat infections. Metronidazole is the one that gives you the disulfiram reaction, and it is the only antibiotic that you really, really, really must not drink alcohol on. We do suggest that you still don't drink antibiotics. Drink alcohol when on antibiotics. And does anyone know why? I'll leave that for you to ponder whilst we go through those. Red man syndrome, vancomycin, and pulmonary fibrosis is the one that we've not really talked about. Nitrofurantoin. So long-term nitrofurantoin use can give you pulmonary fibrosis, idiopathic. And then ototoxic and nephrotoxic. Actually, quite a few antibiotics are like that. So vancomycin can also do the same. But gentamicin is the SBA world one. Okay, it's the one that causes it the most commonly. Does anyone know why we suggest most not drinking alcohol when people are on antibiotics? It's a useful thing, and it links to a type of blood test. It's a very good thought. But in terms of the acute alcohol intake for P450, that's kind of binge drinking. And we probably would advise not binge drinking anyway. The real reason is because antibiotics can cause raised LFTs, so it can damage your liver generally. And we know alcohol does the same thing. So there's fear that both alcohol and antibiotics might sort of make your liver damage worse. Okay, so we suggest avoiding alcohol. This is for Anush.
Yeah, so I kind of struggled with this when I was in fourth year, and so I just made some lists that made it a bit easier. Anaerobes are annoying and tend to hide away and aren't really affected by lots of the usual antibiotics we use. So it's good to know which bacteria are the anaerobes and what you can use against them. So does anyone know any anaerobes? We've talked about one in the GI tract, which is the one I want you to remember. Everything else is not that important. So what's the one? Yeah, so C. diff or any Clostridia are anaerobic. Some forms of E. coli can be, but they're not obligate anaerobes. They're facultative. Basically, it depends on the situation. They can kind of switch. These are obligate anaerobes where you can't. They absolutely have to be anaerobic. We'll talk about Clostridia really briefly in a minute, but does anyone know what Yersinia causes? Has anyone heard of Yersinia pestis? It's a bit of a throwback of a few hundred years.
Well, I was about to say more than a bit of a throwback.
So yeah, this is just a fun fact. Well, a not so fun fact. Yeah, this Yersinia pestis is the plague. So Clostridia, there are 4 Clostridia you need to know for exams, and we'll go through them now because it'll take like 2 minutes. So we talked about C. diff that causes diarrhea. Does anyone know any other types of Clostridia infections? I can get some clues. One's something you might like people may inject into their faces as they get older, and is in one of the episodes of Sherlock in season 1. Yeah, so Clostridium botulinum causes botulism. Yeah. And then what's the opposite of botulism? So botulism is another word for flaccid paralysis. So there is a form of Clostridia that causes paralysis that's the opposite. Yeah, so Clostridium tetani or tetanus toxin causes spastic paralysis. And the last one causes a skin and soft tissue infection where there's gas in the soft tissue. Yeah, Clostridium perfringens. Those are your 4 types of Clostridia. I wouldn't. Yeah, Bacillus. We can talk about another day. No cardio. We don't really need to talk about these. Anti-anaerobic antibiotics. Which 2 have we talked about today? James, do you want to add anything about any of these bacteria?
No, I think just as Anush has done, the 4 different types of Clostridium, just know that sort of one line, what they do. That'll really help you with SBAs.
Yeah. Wow, I didn't know the 4 types of Clostridia like this early in the year, to be fair.
Yeah, it's very impressive.
Yeah, what anti-anaerobic antibiotics did we talk about? There were 2 we talked about.
One that you mustn't drink with alcohol or have alcohol with.
and works for parasites as well. So metronidazole is the important one. What was the other one? The one we accidentally kind of made. So Cipro, not so much. It can. So the one we accidentally made was coamoxiclav. When we stopped it from being broken down by resistant bacteria, we got some anaerobic activity. Carbapenems work really well against anaerobes, and metronidazole. So I would remember metronidazole, and I would remember coamoxiclav specifically because you'll see them used a lot. Carbapenems, as I said, you shouldn't be seen used a lot.
Clarify, Anush, I'm actually not sure. Tazocin, I presume that's also anti-anaerobe.
Tazocin is also anti-anaerobic. I just left it off because we didn't really cover tazocin. Tazocin is basically just
Coamox on steroids.
Yeah, it's just really strong coamox. We'll talk about it some other time because it has more specific use cases. Because we need things to not become resistant against tazocin, basically. And then the last kind of cheat slide is which antibiotics increase the risk of C. diff infection. And these are the C's, and I'll just you can look over these in your own time. But Cipro and the Fluoroquinolones, Clindamycin, specifically, and the cephalosporins. The other macrolides can also increase risk of C. difficile infection, but clindamycin does it more so. So clarithromycin, erythromycin are also correct answers, but clindamycin is the most likely to. They do like testing this as well. This is another thing they like testing. But I think that's everything we were going to cover today.
Yeah, just a handy note for these Cs. They're all very broad spectrum antibiotics, and that's exactly why they predispose to C. diff infection, because broad spectrum, it kills out all the microbiota in the normal bacteria in your gut, and that allows C. diff to sort of predominate. But yes, this was very much a pilot presentation. It just came because I was bored and wanted to try and make antibiotics a bit more fun. Please give honest feedback about whether you found it useful, whether you found it helpful, whether it made it a bit easier at all, or if it was just a bit of a waste of time and you'd have rather we just sort of deal with the facts. It does help because we probably spent quite a lot of time thinking up random heroes to draw to a drug.
Time. I think this is the most time I've ever spent planning a session.
Yeah, so if you give negative feedback, that's fine. It saves us time in the future.
Yeah.
If you like it, that's also fine. We'll try and keep finding ways to make things like this fun. But please give honest feedback. We really don't mind either way.